Learned audience, I am Dr. A.K. Ahmedullah, Assistant Professor from Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University. Welcome you all in this webinar on spondyloarthritis. Before moving into our main scientific part, let us watch a video clip on the scientific activities of Bangladesh Rheumatology Society. Now, may I request Raj TV, please on the video. Can you please show the video clip, please, Raj TV? Thank you, Raj TV. Learned audience, I think you enjoyed the video. Now we are starting the scientific part of the webinar. As you heard, the today's topic is spondyloarthritis. We have two speakers. First speaker is Dr. Alamgir Mushtaq Ahmed. He is a rheumatologist and senior consultant of medicine from District Hospital, Sherpur. And second speaker is Dr. Mohammad Masudul Hassan, rheumatologist of Bangabandhu Sheikh Mujib Medical University and senior consultant of Islamic Bank Hospital, Dhaka. This webinar will be chaired by Professor Syed Atikul Haq, President Bangladesh Rheumatology Society and President of APLA. Today's panel of experts are Professor Ingrid Moller, rheumatologist from Barcelona, Spain, Professor Minhaj Rohim Choudhury, Department of BSMMU and Secretary General of Bangladesh Rheumatology Society, Professor Mohammad Nazrul Islam, Chairman of the Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University, Dr. Shamim Ahmed, Associate Professor, Department of Rheumatology of BSMMU, Dr. Mohammad Abu Shahin, Associate Professor of Rheumatology, BSMMU, Professor Roshan Ara, Rheumatologist and Medicine Specialist, Department of Medicine, Green Life Medical College. Now, I'd like to invite our first speaker, Dr. Alamgir Mushtaq Ahmed, to deliver his speech on overview of clinical manifestation and classification of spondyloarthritis. Dr. Alamgir Mushtaq, please. Dr. Alamgir.
আলমগীর তোমার আনমিউট করতে হবে।
হ্যাঁ, আলমগীর একটু আনমিউট কর। আর I want to say that dear audience, at the end of the presentation there will be a question and answer session. If you have any question, please submit it in the chat box. Our speakers and panel of experts will answer this. Thank you very much.
Sir, you can hear me now? Hello?
Yes.
Okay, now I can start. Assalamu alaikum. Honorable Chairperson, Professor Syed Atikul Haq, and respected panel of experts, Professor Minhaj Rohim Choudhury, Professor Ingrid Moller from Spain, and Professor M.D. Nazrul Islam, Honorable Chairman, Department of Rheumatology, BSMMU, and Dr. M.D. Shamim Ahmed and Dr. M.D. Abu Shahin, Associate Professor of Department of Rheumatology, and Professor Roshan Ara, Rheumatologist, Green Life Hospital, and my yes sir.
স্লাইড শোতে ক্লিক করো আলমগীর, তোমার ওখানে দেখো নিচে স্লাইড শো
আতিক স্যার মিউট আছেন।
আলমগীর নিচে তোমার ডান দিকে স্লাইড শোতে ক্লিক করো, স্লাইড শো না ওই একটু স্লাইড শো আছে দেখো, ওই যে গোল ইয়াটা, হ্যাঁ ওইটা আরো ডান দিকে, আর একটু ডানে, হ্যাঁ আর একটু ডানে, হ্যাঁ এইটাতে হ্যাঁ ওকে গুড, ক্লিক করো।
Yes.
Good.
Now, and my fellow Dr. Abul Khair Ahmedullah and learned participants, welcome you all. Good evening. Now, I am Alamgir Mushtaq Ahmed, going to present the overview of clinical manifestation and classification of spondyloarthritis. You know, spondyloarthritis is a family of disorders sharing a group of clinical features. What are the common clinical features? The most importantly is sacroiliitis, asymmetric oligoarthritis, dactylitis, and enthesitis. And there are some other additional features shared by shared by some form of spondyloarthritis, like psoriasis, genital lesions, conjunctivitis, uveitis and inflammatory bowel disease, preceding or ongoing infection, positive family history, elevated acute phase reactants, and positive HLA-B27 antigen. There are different forms of spondyloarthritis. Most common ankylosing spondylitis, then non-radiographic axial spondyloarthritis, peripheral spondyloarthritis, and spondyloarthritis associated with psoriasis or psoriatic arthritis, spondyloarthritis associated with Crohn's disease and ulcerative colitis, reactive arthritis, and juvenile onset spondyloarthritis. Here we see that undifferentiated spondyloarthritis has disappeared due to wider acceptance of classification criteria of assess classification criteria by the expert. Now, undifferentiated spondyloarthritis can be classified as either peripheral spondyloarthritis or non-radiographic axial spondyloarthritis, depending upon the predominant feature. Another important body, the Assessment of Spondyloarthritis International Society, that is ASAS, has broadly classified spondyloarthritis into two categories. First one is axial spondyloarthritis and peripheral spondyloarthritis. Chronic low back pain or inflammatory back pain is the important feature of spondyloarthritis. And when a patient present with this feature, then we label him as a case of axial spondyloarthritis. And axial spondyloarthritis with definite radiographic sacralitis diagnosed as ankylosing spondylitis. And again, axial spondyloarthritis without radiographic sacralitis or only with very mild changes in radiography, then it can be classified as non-radiographic axial spondyloarthritis. Here it should be noted that in non-radiographic spondyloarthritis, normal radiographic sacralitis may be absent, but on MRI imaging, bone marrow edema can be seen on SI joint. And then patients who have predominant peripheral features, then we can label him as a case of peripheral spondyloarthritis. Now, regarding the epidemiology, in Bangladesh, a recent study suggests that prevalence of spondyloarthritis is 1.2%. And this study is done in Bangladesh on the guidance of in the Department of Rheumatology department, led by Professor Syed Atikul Haq. Among the spondyloarthritis, ankylosing spondylitis and non-radiographic axial spondyloarthritis are the most frequent form, and reactive arthritis is least frequent. Several studies shown that about 5 to 10% of patients with non-radiographic spondyloarthritis ultimately develop positive radiographic features of sacralitis, that is axial spondyloarthritis, within 2 years, and about 20% case within 5 years on follow-up. Now, major musculoskeletal features. The first one is chronic low back pain or inflammatory low back pain. The low back pain, when it is more than 3 months of duration and onset before the age of 45 years, is suggestive of chronic low back pain, and it is an important feature of spondyloarthritis. About 20% of general population having chronic low back pain, but only minority of these develop axial spondyloarthritis. However, in younger age group, we should always try to exclude the spondyloarthritis who are suffering from chronic low back pain. Now, the inflammatory back pain. Inflammatory back pain is defined as follows. When 4 of the following 5 features are present in a patient, then we can say that it is inflammatory back pain. That is onset of back pain before the age of 40, and it is insidious onset that improves with exercise, but no improvement with rest, and pain at night. That is important, pain at night. And there is additional feature of inflammatory back pain, but not listed here. That is a good response to NSAID. If a patient responds within 24 to 48 hours with NSAID, and it is typical of spondyloarthritis. Inflammatory back pain is a characteristic feature of axial spondyloarthritis, but a considerable number of patients with axial spondyloarthritis does not fulfill the criteria of inflammatory back pain. So, the presence or absence of inflammatory back pain alone is insufficient to determine that the patient is suffering from axial spondyloarthritis. Other features must be taken into consideration to make a proper diagnosis. Now the peripheral features, and among the peripheral features, most important is arthritis, and often it is acute onset and predominantly involving the lower limbs, especially knee and ankle joints are commonly involved, and asymmetric in nature, and severity vary from mild to disabling. Again, the presence of asymmetrical oligoarthritis is very suggestive of spondyloarthritis, but the absence of it does not exclude the possibility of spondyloarthritis. Now, the enthesitis is another important feature and is relatively specific to spondyloarthritis. And what is enthesitis? Actually, it is the inflammation around the enthesis. That is the site of insertion of ligament, tendons, joint capsule, or fascia to the bone. And the most important enthesitis is the Achilles enthesitis, and enthesitis at the site of insertion of plantar fascia ligament into the calcaneus. There are some other sites of enthesitis also. That is the iliac crest, greater trochanterus, epicondyles at the elbows, tibial plateaus, costochondral junction at the sternum, humeral tuberosities, manubriosternal joints, occiput, and spinous process. And we can note here that the only Achilles enthesitis show the features of inflammation, that is swelling. On other sites of enthesitis, there is no swelling, but you may elicit tenderness on palpation on that sites. That is the figure, and you can see the swelling at the back of the ankle joint, that is Achilles tendinitis. Now about the dactylitis. Dactylitis is also a characteristic feature of spondyloarthritis, especially it's present in psoriatic arthritis, and sometimes it is also present in reactive arthritis. And how can you differentiate dactylitis and synovitis? In synovitis, inflammation only confined to the joint, but with dactylitis, the entire digit is swollen, giving rise as sausage-shaped digit. And this diffuse swelling is due to inflammation of the flexor tendon sheath, adjacent soft tissue, and the inflammation may also involve the bone and joints. Dactylitis is an important feature, but dactylitis is not specific for spondyloarthritis. It may be seen in some other condition like tuberculosis, syphilis, sarcoidosis, sickle cell disease, and tophaceous gout. So proper evaluation is necessary. And there are some other musculoskeletal features. Among them, anterior chest pain or rib cage pain is relatively non-specific, but alternate buttock pain, that is alternate buttock pain, is more specific for axial spondyloarthritis. Now, the major non-musculoskeletal features, the inflammatory eye disease. Among the inflammatory eye disease, conjunctivitis and uveitis is more important. Conjunctivitis is typically non-purulent and transient, and the symptoms subsides within few weeks. But uveitis, especially the anterior uveitis, is a serious problem. And uveitis, actually, it is the inflammation of the uveal tract of the eye, and it is finally evaluated by the ophthalmologist with a slit lamp examination, and it is a serious problem. And patient complains of redness, pain, and photophobia, and patient may develop blindness if it is not treated well. And uveitis may be the first problem to require medical evaluation for spondyloarthritis. Because acute recurrent unilateral anterior uveitis is very suggestive of spondyloarthritis. Episodes of uveitis do not necessarily parallel to the course of arthritis. That is, all the features of the spondyloarthritis may subside, go in remission, but uveitis may persist for a long time, especially in case of psoriatic arthritis. Now, the inflammation of the bowel mucosa, that is inflammatory bowel disease. Sometimes SPA is associated with the inflammatory bowel disease, and prevalence of inflammatory bowel disease is about 6 to 8% in ankylosing spondylitis. Especially, arthritis is more common in Crohn's disease when it involves the large gut rather than in ulcerative colitis. Psoriasis is also associated with spondyloarthritis. Some experts suggest that all forms of arthritis associated with psoriasis should be classified as part of the SPA family. But it is a matter of debate. And again, when a patient of spondyloarthritis having concomitant psoriasis, peripheral joint involvement is more common and disease course may be more severe. Now we'll go for the investigations. First of all, the acute phase reactants. Here both ESR and CRP are raised, and CRP is more preferable than ESR. And elevated CRP is observed about in almost 40% cases of spondyloarthritis. And CRP is more raised in ankylosing spondylitis in comparison to non-radiographic axial spondyloarthritis. And besides that, CRP also reflects the disease activity. But a normal CRP or ESR does not exclude the diagnosis of spondyloarthritis, or it does not exclude the presence of disease activity. That is, a patient with active spondyloarthritis may have normal ESR or normal CRP. Now the HLB27, it is an important test because it is found about 80 to 95% cases of axial spondyloarthritis and 75 to 85% cases of non-radiographic spondyloarthritis. It is also found in 8% of general population. So a positive test for HLB27 alone is not diagnostic for axial spondyloarthritis. And again, a negative test does not exclude the diagnosis of axial spondyloarthritis. So this test should be considered in context of other clinical features of spondyloarthritis. Positive HLB27 test increase the confidence of diagnosis of axial spondyloarthritis when radiographic sacroiliitis is present, but it is more useful in doubtful cases, especially when radiograph and MRI imaging are equivocal or non-conclusive for the demonstration of edema in sacroiliac joint. A negative test for HLB27 in borderline cases, that is in doubtful cases, reduces the probability of axial spondyloarthritis. That is, the positive HLB27 test increase the probability of diagnosis in suspected cases, and again a negative HLB27 test decrease the probability of diagnosis in a suspected case of axial spondyloarthritis. Now, few words regarding the imaging studies. Plain radiography is very important and sufficient enough to identify the sacroiliitis. What is diagnostic of axial spondyloarthritis? Now, the grading regarding the grading of axial spondyloarthritis, the pictures are not shown here. Why, I don't know. There are several grading. The grade 1 is a normal, and grade 2 is in suspicious changes are present in sacroiliac joint, and grade 2 there is minimal abnormality, that is localized sclerosis or erosion, but there is no widening or narrowing of the joint space. And grade 3, there is moderate or advanced sclerosis or erosion, and there is change of joint space like narrowing, and in some case you may get some partial ankylosis. And grade 4 is total ankylosis of the joint. Sorry. Okay. It is grade 5, there's complete ankylosis. Sacroiliitis bilaterally grade 2 or higher, or sacroiliitis unilaterally grade 3 or higher, changes are significant for a diagnosis of axial spondyloarthritis. Now, radiograph of the spine. Radiography of the spine shows the different shows the progression of the disease, like from the Romanas sign, squaring of the vertebral body, and syndesmophyte formation, and ultimate ankylosis of the vertebral body, giving rise to bamboo spine. But it is less helpful for the diagnosis purpose. For the diagnostic purpose, sacroiliac joint inflammation, finding of sacroiliac joint inflammation is more important. But radiography of the spine actually shows the disease progression. Now the MRI. MRI actually indicated when plain radiography failed to demonstrate the SI joint inflammation, or when the plain radiography is contraindicated, especially in pregnancy. The plain radiography is contraindicated. In that case, we can get help from the MRI imaging. And MRI shows the bone marrow edema in subchondral area. It is a MRI of sacroiliac joint. That is the hyperintense lesion in T2-I8 image with fat suppression on both sides of sacroiliac joint in both SI joint. There are some points regarding the MRI of SI joint. Should be noted, the active sacroiliitis may not be present in advanced ankylosing spondylitis. And not all patients with non-radiographic axial spondyloarthritis have abnormal MRI findings. And in some cases, false positive findings may be found, especially in case of infection, malignancy, and osteitis condensus ileae. So, a positive MRI alone is not diagnostic for spondyloarthritis. It should be interpreted in the context of other clinical findings and other clinical and laboratory findings. MRI of the spine. MRI of the spine is not commonly used for the diagnostic purpose, but it can be done on the most painful area of the spine in a highly suspicious case of non-radiographic axial spondyloarthritis, especially when plain radiography and MRI fail to demonstrate the SI joint inflammation in non-radiographic axial spondyloarthritis. In that case, the most painful area, MRI on the most painful area may demonstrate the anterior or posterior spondylitis. There is a figure here. You can see that spondylitis, demonstrated in the vertebral bodies in T2-I8 image, and there is fat suppression, fat deposition in the T1-I8 image, more evident here. And imaging of the enthesitis, the ultrasound and MRI can detect the changes of enthesitis. And this is a ultrasound figure of Achilles enthesitis. You may see here the hypoechogenicity and erosion of the calcaneum joint. There is formation of bone spur as well as Doppler activities. It is suggest these changes are suggestive of enthesitis. For here, I have not discussed about the physical examination findings because the caliber of the lecture may be large enough to break your concentration. But for the diagnostic purpose, a thorough physical examination, especially all the joints, including SI joint, should be examined properly, and sites of enthesis and spine flexibility of the spine as well, skin, genitalia, and eye properly should be examined to reach the diagnosis. From the previous discussion, we have seen that no single historical feature, physical findings, lab test, or imaging test are sufficient to establish the diagnosis without the presence of other abnormalities. So, in a suspected case of spondyloarthritis, a thorough history, physical examination, and lab testing should be done. And after all that, if we fail to diagnose a case as a case of spondyloarthritis, then wait and see policy may be the appropriate approach. Now we will go for the classification criteria done by ASAS. And ASAS classification criteria is widely accepted by the experts in SPA. And it has replaced the older classification like modified New York classification criteria for S, European spondyloarthritis study group criteria, and AMOR criteria as well. Now the ASAS classification criteria. ASAS, we have seen previously that ASAS has broadly divided SPA into two categories, like axial SPA and peripheral SPA. Now the axial SPA. To diagnose a case of axial SPA, patient must have chronic low back pain in the entry step. Patient must have chronic low back pain in the entry step. And on the second step, patient either have sacroiliitis on imaging or either have HLA-27 antigen. When a patient presents with chronic low back pain and positive radiographic sacroiliitis and another one SPA features listed below, then we can label him as a case of axial spondyloarthritis. On the other hand, a patient with chronic low back pain having HLA-27 positive but no sacroiliitis on imaging and having two other SPA features listed below may be labeled as axial spondyloarthritis. There are some 11 SPA features are listed here. You know well. Now the peripheral spondyloarthritis. In peripheral spondyloarthritis, peripheral features, especially arthritis, enthesitis, and dactylitis are most important, and patient must not have concurrent inflammatory low back pain. Again, in peripheral spondyloarthritis, patient must not have concurrent inflammatory back pain. So the entry step is patient must have at least one of the following three, like arthritis or enthesitis or dactylitis. It is the entry step, and in the second step, when patient is satisfied the entry criteria, then we go for the second step. Then in second step, if the patient have at least one of the SPA features in group A or at least two of the SPA features from group B, then we can label him as a case of peripheral spondyloarthritis. It should be noted here that the one single features should not be counted two times in both entry step and in the second step. Strict adherence to the ASES classification criteria may lead to some false positive or false negative diagnosis in about 10% cases in both sides. So what are the strategies to reduce the false negative diagnosis? There we know that in axial spondyloarthritis, the chronic low back pain is should be for more than 3 months. But there are some cases of axial spondyloarthritis having low back pain, inflammatory back pain, but duration is not sufficient enough. And this may be considered, then we can avoid the false negative cases. And again, age of the onset of pain may also be compromised. And in the absence of HLA-27 antigen, sacralitis on plain radiography, and in the absence of HLA-27 antigen and sacralitis on plain radiography, we can get help from the MRI imaging. And in this way, we can reduce the false negative cases. And again, there are strategies for the to reduce the false positive cases. That is, the axial spondyloarthritis is unlikely, it's very unlikely if all three features, that is inflammatory back pain, HLA-B27 antigen, and imaging changes of sacralitis are absent. So if we stick on these 3 points, then we can avoid some false positive cases. Dear audience, I am at the terminal part of my lecture. Now, I like to request you to concentrate on the take-home messages. According to ASAS, SPA is broadly classified into 2 categories. You know, the axial and peripheral spondyloarthritis, and presence of chronic low back pain is the main determinant. A large proportion of patients of non-radiographic axial spondyloarthritis evolve into ankylosing spondylitis in course of time. No single clinical feature, laboratory test, or imaging findings are sufficient enough to make the diagnosis. Alternate buttock pain is more specific to spondyloarthritis. Enthesitis is relatively specific for spondyloarthritis, and again, dactylitis is an important feature of psoriatic arthritis and reactive arthritis. Uveitis may be the first problem to require medical evaluation for spondyloarthritis. A good response to NSAID within 24 to 48 hours is more typical of spondyloarthritis. Strict adherence to classification criteria, especially the ASAS classification criteria, may lead to both false positive and false negative cases. So physician's evaluation and consideration is important to reach the proper diagnosis. Thank you all for patience hearing, and I would like to thank especially Professor Minhaj Chaudhary to inspire me and to help a lot to make this presentation. Again, thank you all.
Thank you, Dr. Alamgir. It's a beautiful presentation. We enjoyed it a lot. And now I'd like to request Dr. Mahfudul Hassan to deliver his speech on treatment of spondyloarthritis.
One microphone needs to be mute because we are getting some noises very much disturbing. Please check and try to stop it. Mute it.
Thank you, Dr. Ahmedullah, and respected chairperson and our other respected panel of experts and also our intelligent and viewers. My topics is treatment of axial spondyloarthritis, and I will go as quick as possible. Before starting the treatment of axial spondyloarthritis, I want to say the journey of spondyloarthritis. The journey of spondyloarthritis started centuries back, but the history says the condition was first fully described in the late 1600s by Bernard Connor, and the first skeleton that was found features of ankylosing spondylitis was in Egyptian mummies. And then the journey started in the last century. It criteria that my previous lecturer enumerates. These are the criteria, and diagnosing at this moment the most accepted and widely used criteria is the ASAS criteria, and and Euler bodies have adopted this criteria spondyloarthritis. Actually, axial spondyloarthritis comprises both radiographic sacroiliitis and without radiographic sacroiliitis. But it is not actually different entities. It is one disease in same patients with anorexial SPA may develop radiographic changes over time. And before going to the management, I want to say that we always should follow recommendations, because individualization sometimes lead to biasness. And for the recommendations, again, the most learned body in the world is the ACR and Euler, and they recommended recommendations assess bodies, and this assessment is widely accepted. And 2016, there is an update of these recommendations in the management of axial spondyloarthritis. I will highlight on these recommendations mainly, and then I will go to the details as short as possible. First recommendation is it should be a multidisciplinary management, and multidisciplinary management should be coordinated by the rheumatologist. Which discipline should be involved, and according to the patient condition, rheumatologist will decide. And where rheumatologist is not available, expert on rheumatological diseases will coordinate the condition. And our goal, how can we maximize the health-related quality of life? And this can be achieved by controlling the symptoms, inflammations, by preventing the progressive structural damage, and also by preserving and normalization of function and social participations, increasing the social participations. There are two parts of the treatment. One is non-pharmacological treatment and other is pharmacological treatment. Before discussing the non-pharmacological pharmacological treatment, a good relationship between the patient and the rheumatologist is important, and a rheumatologist should not put the decision on the patient like that you have to do this and that. There should be a shared decision. Patient must be educated, and that education to be optimum, that the patient know every pros and cons about the disease, its etiology, its pathophysiology, its drugs used, prognosis, and the cost of the drugs, adverse effects of the drugs, and even how it can affect his offsprings in future. And then patient, as well as the patient's family members, those who care about the patient, should also be part of this shared decision process. This is very crucial for longitudinal management. And another crucial part is the cost. And we have to know the patient's income, his family support, his family expenditure, and how much he can spend on his treatment cost, on treatment purpose. And with considering all these things, we have to plan about the treatment. And that will be more practical and more cost effective. Then we have to individualize the patient's treatment by current signs, symptoms, and the involvement of axial, peripheral, or extra-articular manifestations, as well as the comorbidities and psychosocial factors. Next recommendation is how we will monitor the patient. We will discuss it later. We will monitor by patient reported outcome, clinical findings, laboratory tests, and instruments. And next recommendation is how we'll monitor and what will be the frequency. It will be decided by individual basis, but still there are some direction how we will monitor the patient. And in spondyloarthritis patients, exercise has very positive role in the disease process, and we should encourage the patient both recreational and also planned physical therapies involving the physiatrist also. And we also make the patient and convince him to stop smoking if the patient smoke, and we have to educate the patient how smoking affects the spondyloarthritis management. Now for treatment. In the treatment part, the cornerstone of treatment of the axial spondyloarthritis is NSAID. And NSAID can reduce the pain and stiffness and is the first line drug. We can use NSAID continuously, and it is preferred who respond well to NSAIDs. Sometimes paracetamol and opioid-like drugs are used if there is residual pain or NSAID is contraindicated or poorly tolerated. When we will call treatment failure, all patients should have adequate therapeutic trials. And these adequate therapeutic trials for at least 3 months at maximum recommended or tolerated anti-inflammatory dose unless contraindicated. And treatment of less than 3 months where treatment was withdrawn because of intolerance, toxicity, or contraindication. How we will choose NSAID in special situations. In cardiovascular disease, naproxen is considered better, and in GI disturbance, COX-2 inhibitors. In renal impairment, tramadol, paracetamol, sulindac, low-dose ibuprofen can be chosen, but there are some argument about the use of this. This is collected from the up-to-date 2021. But should we continue the NSAID continuously? Here is a study did not reduce radiographic progression compared with on-demand treatment in ankylosing spondylitis. So continuous treatment is used as per needed also. And another important recommendation is we should not use systemic glucocorticoid for long-term treatment, as long-term treatment with systemic glucocorticoid has no role in axial spondyloarthritis. In axial spondyloarthritis, if there is additional peripheral involvement, we can there use local steroids, and if severe enough, then according to peripheral involvement, not in axial. Patients with conventional synthetic DMRDs, as because they're proven and the bodies are not now recommending use of these drugs. But previously, there are some studies which claim that sulfasalazine has some role, but now it is recommended. So, what are the phases of recommendations? In phase 1, after diagnosing the axial spondyloarthritis, if the patient is symptomatic, we should start NSAID in the maximum tolerated dose. And we consider all patients with physical therapy, education, regular exercise, stop smoking, as I described earlier. And NSAID should be at least failure. 2 courses of NSAID, 2 different NSAIDs. Then we will consider the patient has failed to response, and then it will enter the phase 2. And in purely axial disease in phase 2, lack of efficacy and toxicity in phase 1, we will calculate ASDAS and BASDAI. I will discuss it in monitoring. And if ASDAS is more than 2.1 or BASDAI is more than 4, and positive rheumatologist opinion that the patient is not responding to NSAID, then we will go for the next steps. I will come in later, and this is a shortcut of that phases. And in phase 2, if we fail in NSAID trials, then we will enter into the phase 2, and phase 2 is start biological DMRDs, and in biological DMRDs, current practice type is TNF inhibitor therapy. And if TNF inhibitor therapy fails or contraindicated, then we will switch to another TNF inhibitor or interleukin-17 inhibitor therapy. In sustained remissions, biologic DMRDs can be considered. Tapering of biologic DMRDs can be considered. Now, ASAs have a consensus statement for the use of anti-TNF, and as anti-TNF is the main drug in phase 2. So how this we will choose patient? We'll select the patient by patients. If the patient normally fulfilling the criteria for definitive ankylosing spondylitis, and before using grade 2 sacroiliitis or grade 3 or grade 4 unilaterally. And clinically, there should be 2 of the following 3: low back pain and stiffness for more than 3 months, which improves with exercise, but is not relieved by rest, and limitation of motion of the spine in the sagittal and frontal planes, and limitation of chest expansion relative to normal values correlated for age and sex. And we have to define the active disease. The patient must have active disease for more than 4 weeks, and BASDAI more than or equal to 4, and there should be an expert opinion, and an expert is a rheumatologist. Now, how we will assess the response? The responder criteria by BASDAI is 50% of the relative change or absolute change of 20 millimeter on a scale between 0 to 100, and expert opinion in favor of continuation. Time of evaluation is considered between 6 and 12 weeks. Now, contraindications. Anti-TNF contraindications are women who are pregnant or breastfeeding, and effective contraception must be practiced in women taking anti-TNF, and active infections history of lupus or multiple sclerosis, malignancy or pre-malignancy states, including basal cell carcinoma, and diagnosed malignancy and were treated more than 10 years back, where the probability of total cure is very high. And patients at high risk of infection. What are the high risks? Risks are they are chronic ulcers, previous to in a native joint within the past 12 months, sepsis of a prosthetic joint, or persistent or recurrent chest infections, indwelling urinary catheter. The anti-TNF therapy, we have to follow the Latin TB guideline. This is a guideline, the Immunology Journal, it is published, and this guideline is advanced, and it is we have to do the test, TST, tuberculosis skin test, and IGRA, interferon gamma ray, unvaccinated. And if there is BCG vaccinated, we'll interferon gamma ray assay test. Now, in unvaccinated BCG, if both are negative, annual screening with TST and IGRA in high risk group. And if do a chest X-ray and other clinical examinations to exclude active tuberculosis. Those who are BCG vaccinated, they should perform only assay test. If IGRA is negative, annual screening with TST and IGRA in, then chest X-ray and other measures to exclude active tuberculosis. If active TB is diagnosed, active TB treatment. If active TB excluded, education on tuberculosis, preventive therapy for latent TB treatment, start biologics. Vaccination. Vaccination is a very important part of the treatment in patients with who get biologics as well as conventional GMRDs also. So here is the guideline where there are some overarching principles who will get these vaccines, but I'm going to the vaccines in which there are non-live, inactivated, killed, subunit or recombinant vaccines, such as pneumococcus PCV13 and PPSV13. All patients who have not been vaccinated previously, and also seasonal influenza virus annually for all patients, hepatitis A virus at risk patients who have not been previously vaccinated, hepatitis B virus at risk patients, those with occupational or lifestyle risk factors who have not been previously vaccinated, and antibody titers should be checked following completion of vaccine series to ensure response. And non-live, inactivated, killed or subunit or recombinant meningococcus at risk patients who have not been previously vaccinated, including those treated with eculizumab and those with impaired clinic function. Morpheus influenza at risk patients who have not been previously vaccinated. Human papilloma virus at risk patients who have not been previously vaccinated. And other vaccines, those doesn't follow the schedule, childhood schedules. I copied this from my Professor Minhaj Rahim Chowdhury. In short, vaccination schedule for the for starting biologics, and the tools, domains, and instruments we use for function. We follow BAS-5, pain, NRS or VAS, numeric scale, reading scale, and visual analog scale. And spinal mobility, chest expansion, modified Schober, occiput to wall, cervical rotation, lateral spinal flexion or BAS-ME, patient global NRS and visual analog stiffness, and fatigue questions by BAS-DIE. This tool is used for spinal pain. This is for patient global. This is for stiffness of the spine, and this is BAS-DIE in 1994. BASDAI was adopted, and this BASDAI is bath ankylosing spondylitis disease activity indices. This bath is actually a place in England where this tool was developed by the rheumatologist and physiotherapist. This is the BASDAI and the calculation. This is the BASPHI, and this is BASMI meteorological index. And then we usually follow the patient both in clinical practice as well as in the research, ASDAS and BASDAI. This is ASDAS, ankylosing spondylitis disease activity score. These are the parameters used, and we calculate. But you can get these tools in the apps store, so you did not need to calculate like this. You can put the figure there, and they will calculate and give you the result. ASDAS CRP is preferred over ESR if there is CRP is available, and CRP should be in milligram per liter. So you have to look at the unit before calculating. And if CRP is not available, then you can use ESR. Improvement criteria. There are ASAS improvement criteria. So is improvement of 40% of the above 4. One is patient global, pain, function, and inflammation in more than 2 units in at least 3 domains, and no worsening at all in remaining domain. 20% improvement, no worsening in remaining domain. There is 5/6 improvement criteria in 6 domains. There are the domains here mentioned. Improvement of more than 20% in at least 5 domains is the ASAS 5/6 improvement criteria. And this is the ASAS partial remission criteria. And this is a value not above 2 units in each of the domain on a scale of 10 is the partial remission criteria. So how ASDAS tells you when disease is inactive. If it is less than 1.3, we can predict the disease is inactive. Low disease activity less than 2.1, high disease activity 2.1 to 3.5, very high disease activity more than 3.5. And during treatment, how can we assess the clinical improvement? If there is improvement in 1.1 score, then it is clinically important. The improvement is there. And major improvement if there is 2-point change. There are few drugs we tried in Bangladesh as well as internationally. It was tried, but for side effect and international bodies did not adopt it for its regular use, but it have some efficacy and that were reported. And we also have one study where many studies. One is I have shown also. So there are many studies done for both thalidomide and pamidronate under leadership of Soyed Atikul Haq, Nazrul Islam, and Minhaj Rahim Chowdhury. And new drugs, the biosimilar, tofacitinib. And there is a publication in phase 2 trial. In patients with ankylosing spondylitis, there is a 16 weeks randomized placebo-controlled dose-ranging study shows greater efficacy versus placebo in reducing symptoms and objective endpoints of active ankylosing spondylitis in adult patients with a similar 12-week safety profile as reported in other indications. I could not make the slide, but we have another study in Bangladesh by our one of the rheumatologists, Dr. Asad, and our teachers guide them. And here also they found tofacitinib is effective in axial spondyloarthritis. Now, where surgery or which surgery is important, especially total hip arthroplasty. Sometimes we fail to improve, and there are some changes that cannot be corrected by only treatment. Then total hip arthroplasty is essential, and there are some spinal corrective osteotomy, but these all should be done in a specialized center where there is severe disabling deformity. And this slide I have collected from our teacher, my teacher, Professor Minhaz Rahim Choudhury. And also most of the slide I prepared with the knowledge and some help from both Professor Syed Atikul Haq and also Professor Nazrul Islam sir. Future potential targets are matrix metalloproteinase, transporter associated with antigen processing, large multifunctional proteasomes, retinoic acid-related orphan nuclear receptors, signal transducers and activators of transcriptions, small regulatory protein, proteoglycan aggrecan, glycoprotein in ECM. So I have a brief conclusion. That is, I think patient education is critical for management, and adopting standard body recommendations are important to avoid the bias and also overconfidence. And vaccination and latent TB infection should be addressed, and we should use measuring tools in managing axial SPA, both in our practice as well as in research. Thank you very much. Thank you, everyone, to give me the opportunity to give this lecture. Thank you very much.
Where is our moderator, facilitator, Dr. Ahmedullah?
Thank you, Dr. Masudul Hassan. You talked very nicely on a complicated topic. Now, I like to invite the speakers for question and answer session. I have seen that there are a lot of questions in the chat box. As we have time constraint, I like to take permission from the chair, our chairman, sir, chairperson, Professor Syed Atikul Haq. Can we allow all the questions to be answered, or some selected ones? Atik sir, please.
I think you have to select the questions because, we cannot include all the questions. It may take whole night. So you have to pick up the questions, and you also find that, there are, it is also happening that 3 or 4 questions have similarly, almost same basic theme. So you may consolidate them into one single question. Is better that,
Okay.
Ahmed, you pick up the questions and you throw to the speakers and the panelists, okay?
Okay. Sir, Jiaul Haidar and Mamun Khan, to the first speaker. Which view of the X-ray is best to demonstrate sacroiliitis? And Dr. Mamun Khan asked if a patient came with back pain, significant spinal changes like erosion, squaring, Romanas sign, but imaging shows MRI and MRI shows negative sacroiliitis, probably sacroiliitis, and HLA-B27 not negative. Can we classify him as axial SPA? Dr. Alamgir Mustaq.
Yes. Thank you for the questions. First question is which view of SI joint is more appropriate for evaluation of sacroiliitis? Yes, oblique view might be more appropriate due to tilting of the SI joint. So oblique view may be more appropriate to evaluate the sacroiliac joint. In epi view, there is some overlapping. So it may be confused. There may be confusion regarding the presence or absence of sacroiliitis. But epi view is more preferable regarding that it is cost convenient, as well as it also identifies some other changes accept SI joint also. Like it can identify any abnormality in the hip joints as well. It can show some osteitis or erosion in the greater trochanter's pubic iliac crest, or it may some changes in the pubic symphysis also. So considering all these factors, we usually advise for extra pelvis epiview.
Doctor, thank you. Alamgir, Dr. Sabrina Yasmin asked a question. In ASAS classification criteria for axial SPA, we can see the low back pain, the class more than 3 months, and age at onset less than 45 years. But the definition of low back pain is age at onset is less than 40 years, which can produce difficulties in doing research. I'd like to hear something from the first speaker or expert panel regarding this. It is a dilemma.
Actually, as in ASAS classification criteria, for the diagnosis of axial spondyloarthritis, in the entry step is the chronic low back pain. It may or may not be the inflammatory back pain, but chronic low back pain presence of chronic low back pain is important. But in chronic low back pain, age boundary is it must be less than 45 years, but in inflammatory back pain, it is less than 40 years. Why this variation, actually, I don't know. So I can refer this question to the expert panelist.
Sir, anyone from expert panel?
I think Dr. Abu Shaheen or Roshan Ara,
Okay.
younger group can respond. Yeah.
Actually, for the diagnosis of axial SPA, I think ASAS criteria clearly mentioned the entry criteria as well as other SPA criteria, SPA features. And in that case, here it is clearly mentioned low back pain, no need to say inflammatory or non-inflammatory. The question from Dr. Sabrina, I think we should not confused with the age 40 years. We should consider the ASAS criteria 3 years, 3 months, more than 3 months, and age more than 45 years. I think we should consider these age. We should not confused with the definition or the age less than 40. Anything Dr. Roshanara may add because she has a lot of experience on low back pain.
রওশন আনমিউট করে নাও। রওশন আনমিউট করো।
Sorry, I would like to thank Dr. Abu Shaheen. I think he already clarified the topic and the question asked by Dr. Sabrina. And Dr. Sabrina probably want to know whether when we put a diagnostic criteria for a research purpose, so non-specific low back pain or other inflammatory low back pain definition and ASAS criteria may contradict a little bit. I think it's the researcher's own researcher can get the own view for that particular study, which is he or she would like to take, and what they want to. If you want to diagnose according to ASAS criteria, then this is the 45 years. But if it's a low back pain as a whole, you can take it 40. It's not been a huge problem, I guess. Thank you.
I think a little I would like to add here, Sabrina, nothing problem in this case. You need to keep in mind you are going to follow the ASAS criteria, but we need to keep in mind, I would like to say Alamgir as well, This is the inflammatory back pain. 3 months is the duration. Inflammatory back pain is the issue. Need to be with this, and don't march that the 40 years with the assess criteria. When you are following the assess criteria, just follow whether the patient fulfilling the low inflammatory back pain criteria or not, and then enroll your case for the research. Ahmed, you can
Okay, sir.
proceed. Proceed.
Thank you, sir. But I think due to time constraint, the last question from Mamun Khan is anti-TNF is contraindicated in all trimester of pregnancy or only third trimester? To Dr. Masudul Hassan, please, or any other expert.
প্রেগনেন্সিতে তো অ্যান্টি টিএনএফ আমি তো ওই প্রেগনেন্সিতে ইউজ না করার জন্যই মনে হয় অ্যাডভোকেট। এটা ছাড়া কি বলে প্রেগনেন্সিতে অ্যান্টি টিএনএফ ব্যবহারের পক্ষে নাই।
May I invite anyone?
চ্যাট বক্সে একটা কোশ্চেন আছে যে আহমেদ ভাই বারিসিটিনিব নিয়ে একটা কোশ্চেন আছে চ্যাট বক্সে, এটা আমি দেখলাম। আমি ক্যান আই আনসার দ্যাট কোশ্চেন?
Okay, please answer that.
Baricitinib,
Okay, yes.
Jiaul had asked, thanks for, is there any role of baricitinib in the management of SPA? Here, I looked for the studies, but I got two studies. One is tofacitinib and another is filgotinib. They have some role, and as the study shows, but the baricitinib producing companies claim this may also have some role in axial spondyloarthritis. We need some of this. Still, there is no convincing evidence. Studies are going on. Thank you very much.
I would like to
about the
regarding the pregnancy.
Oh yeah, Roshan, you would like to answer? Okay, you can proceed.
Okay, thank you for this nice question. TNF inhibitors can be given up to up to second trimester and or the early third trimester. Most of the TNF, if the benefit is outweigh risk, even we can continue. The problem is there is no much studies regarding TNF inhibitors and pregnancy continuing throughout the pregnancy, except cetulizumab pegol, which is not available in our country. It can be given throughout the pregnancy period, and others we have to stop. The recommendation is to stop before third trimester, and if we have to continue, only in case of benefit outweigh risk. And for those patients who are receiving anti-TNF, the baby should not receive live vaccine after delivery. That is the precaution we have to remember. Thank you so much.
Thank you, Professor Roshan. Now, due to time constraint, I like to go to panel of experts. May I request Professor Ingrid Moller to comment, to give his few valuable comments on spondyloarthritis, and also one of our
thank you very much.
Thank you. One of our phase B student wanted to know whether there is any role of ultrasound for detection of early SPA.
Yes, very good question. She will love to answer.
Thank you very much. I'm very happy to answer this question. But first of all, congratulations. This is a great meeting, and the speakers were really brilliant. Thank you very much. We were learning a lot, and Luis, our fellow, was very impressed about the level of the speakers. Thank you very much for that. So about ultrasound, yes, we use ultrasound in all our patients under suspicion of spondylitis, and we do a kind of review of the main enthesis. And if it's the first appointment, obviously after a good clinical report, after a good physical examination, we do this scan of the enthesis. And this is very easy to do if you have ultrasound machine. And that can give you some light in case you have doubts, in case you have a positive finding in the enthesis, that is really confirming what you think about this young patient with this inflammatory pain. In case the patient is also doing sport, a lot of sport, strong sport, or the patient is an old patient that maybe can have other causes, well, we need to evaluate other possibilities. But in young patients, when we see enthesitis, the classical enthesitis with the Doppler signal over the bone, we are quite sure that this patient will have spondylitis. Obviously, we will confirm with the whole picture, not only one test with ultrasound. We need to have the complete image of the patient. But this is very, very helpful for us. Yes. Thank you for the question.
Thank you, Professor Moller. Professor Roshan, do you want to tell anything? Do you have any opinion?
I would like to thank the Bangladesh Rheumatologist Society for organizing such a nice webinar on spondyloarthritis. Nowadays, spondyloarthritis is getting much more attention. We used to know that the RA is the most common rheumatic disorders worldwide, but nowadays the changing concepts is that together all the spondyloarthritis, it's much more, maybe much more common, or at least not less than rheumatoid arthritis. There was another conception was it is a disease of young male, which is also changing because now we are getting a lot of spondyloarthritis patients across the age group. And there are a lot of female patients are diagnosing with spondyloarthritis. So it's a changing concepts we have to get along with. And the classification criteria also being changed. Now it's broadly classified like axial and peripheral because of the difference in the management strategies. So we need to know all the concepts clearly so that we can serve our patient better. And the other group of spondyloarthritis like psoriatic arthritis, reactive arthritis, and spondyloarthritis associated with inflammatory bowel diseases. These are also has to be classified like axial and peripheral, and sometimes it's combined. And the diagnostic criteria, which been used so long, like modified New criteria, which usually we see that it 9 to 11 years lack of diagnosis, there is a delay of diagnosis. So now the ASAS criteria, still we have to remember these are the classification criteria. These are not diagnostic criteria. So we have to remember that it's the physician who is the sole authority of a diagnosis any disease. Not we have to put all these criteria in only way of diagnosing a disease. And finally, again, I would like to thank both the speakers for their beautiful presentation and all the panel of experts for their time, and Bangladesh Rheumatologist Society giving me this opportunity to talk. Thank you so much.
Thank you, Dr. Roshan. Professor Roshan, may I invite Dr. Mohammad Abu Shahin to say something on spondyloarthritis.
Thank you, Dr. A.K. Ahmedullah. Today's discussion, our topic of discussion is spondyloarthritis. This is a common problem, a common rheumatic problem. Actually, a spondyloarthritis is under the term of umbrella, the big umbrella, which covers many inflammatory diseases that affect back, neck, as well as internal organs, especially eyes also. I think Dr. Alamgir Mustaq Ahmed already discussed because this spondyloarthritis patients, there are many symptoms, and sometimes it is difficult to diagnose accurately, because sometimes patients don't have any inflammatory low back pain, sometimes X-ray may be normal, even MRI may be normal, ESR CRP sometimes normal. So I must appreciate Dr. Alamgir Mustaq Ahmed. He nicely covered all the aspect, especially clinical manifestations and classification criteria of spondyloarthropathy to diagnose the or to label the case as a spondyloarthropathy. Our another speaker, Dr. Masudul Hassan. Dr. Masudul Hassan nicely presents the treatment aspect of spondyloarthropathy, especially in the era of biologics. Here in our country, Bangladesh, in tuberculosis endemic area, there is a great problem during treatment of biologics, especially including tofacitinib, small molecules. He nicely discussed, deliberately mentioned the latent tuberculosis. So I must thank Dr. Masudul Hassan for his nice presentation. Thank you, Dr. Eka Ahmedullah.
Dr. Ahmedullah sir, can I have some question to Atik sir and some other speakers?
Okay, please.
One or two questions. Your time. Why didn't you ask it before? Okay, one question I think Shweb can ask. Yes.
With the permission of chairperson.
Yes, if he allows.
Okay.
Specifically, I did discuss the issue with Professor Atkul Haq sir regarding that sometimes we get some patients that those who doesn't have any ESR or CRP is normal, MRI, even X-ray and MRI is also normal. So, and even HLA-B27 is also never is normal. So, তাদের ক্ষেত্রে ওনাদের ক্ষেত্রে we can't fulfill the true classification criteria of these patients. So, how to label these patients? Recently, I have encountered one article regarding this, that in the Oxford Rheumatology, that they have labeled these patients as true non-radiographic axial SPA because they have more female predominance, ESR CRP normal, MRI normal, and HLA-B27 normal, and eventually the age of onset is even after the age of 40 years. And those who fulfill these criteria, they have labeled these patients as early radiographic, early non-radiographic axial SPA. So I want to clarify this issue and take a comment from Sir Atkul Haq sir. And the second one is my question is regarding the use of small molecules regarding in the management of axial spondyloarthritis. I think that I may be wrong, but too far my knowledge is that Taiwan Rheumatology Association has possibly put it in the first guideline. They have put it the role of small molecules side by side with the use of biologics in the management of axial spondyloarthritis. And till date, possibly 3 small molecules are included in the phase 3 trials. These are tofacitinib, upadacitinib, and filgotinib. And actively recruitment trial is going on with tofacitinib and upadacitinib. And filgotinib is not, they just recently have started that trial, but they have not started their recruitment yet. So I think that we can use tofacitinib and upadacitinib for the management of refractory axial SPA for this patient. So these are 2 questions, and I want to comment from my valuable teachers.
Okay, thank you. Ahmed, just keep it. I shall address these two during my concluding remarks. Okay, I think you will allow the chairperson concluding remarks. So I shall address these issues. Yeah, okay. Just you switch on to the panelist. Okay.
Now, may I request Professor Mohammad Nazrul Islam, Chairman, Department of Rheumatology. Nazrul sir, please.
Ahmed. Thank you. Thank you very much for giving me the floor. It's a pleasure to see all you together and one of the activities of the Bangladesh Rheumatology Society. And nice. I would like to thank both the speakers. They have given time to prepare their talks. I would like to thank the participants, especially seeing the lot many questions, it says me they do have a lot many enthusiasm with them to have the answer of many questions. So it's a very important aspect. Today, we don't have enough time to mention many of the things, but I would like to inform you some of the aspects. There's been some of the aspects been covered, and we need to take care about the remaining. Number one thing is the imaging. Imaging plays an important role in making the diagnosis of spondyloarthritis, but the imaging is also now a question to interpret, as because there are some other conditions that can confuse with the MRI findings of the SI joints and others. So those who are in interest of doing the research or study the SPA, they need to be a more open eye on these imaging reports. HLA-B27 utility is again another aspect about the other extra articular features, especially the uveitis. So the HLA positivity, if in a case that says that to take care about the possibility of uveitis in this group of case. One part not been covered, if isolated uveitis is there, no rheumatic complaint. So in that group of case, how to treat and how long to treat, as because this is a disease where no predictive points we know till that. We have done some study. There are lot many studies we have done in our department, possibly for time constraint. Masood didn't mention that works about these are some of the issues need to be keep in mind. So even the developing countries where the DMRs and other things are not in hand. So even in my center and in my own practice, possibly Atik sir, Minhaj bhai will agree with me. We are using the azathioprine still today to treat your uveitis. So this is another aspect. Before selecting the imaging and then CRP. CRP is the very important one, cannot be positive. Students also asked about this one. So I think you know the CRP gene polymorphism can play important role of keeping CRP negative in this group of case. One important and interesting question been put by the students, is it a autoimmune disease, autoimmune disease or something like that? Very interesting part. We can till date, we can say it's an auto-inflammatory disease. So the autoinflammatory meaning is the innate immunity plays a role in the pathogenesis of SPA, but we are still lagging behind to tell it autoimmune disease. So it is an autoinflammatory and the autoimmune issue is still in our hand. We know it's an autoinflammatory disease related to the innate immunity and that related to the T cell and the B cell. Other way about the treatment, different options, the TNF blockers are, we are using a one modified dose. And for all of your information, that modified dose is that etanercept series. Everybody, you know, we are doing a study, long study, 2-arm study. In one arm, we are using the lower dose etanercept, comparing it to the tofacitinib. This is ongoing one. And from our observations, we are switching the patients to the 15 milligram, those who are not responding to the 10 milligram tofacitinib. This is going on, we are keeping the data. And then the lower dose etanercept, I have found safe with even in the last trimester, nothing happened with the babies. Those are heavy, severe pain. If you treat with the etanercept in all along the course, but for precaution to save the baby for the live attenuated vaccine and so, we can stop the drug in the last trimester. So the SPA is a big spectrum, and the physician needs to be very careful about assessing the case, making the diagnosis, starting the treatment, and the follow-up, as because it's a disease of lifelong. And lastly, would like to say to all you all, APLAR developed a guideline, and that guideline is in the domain, APLAR domain. Everybody you can get it, and this is the special interest group, SIG group. I was also involved with them. There we have mentioned systemic steroid should not be used more than 15 days. So this is another information. Our guideline is there, and that guideline is a little different from the ACR and Euler, that keeping in mind in the Asia Pacific region, we do have many developing countries. So to serve our poor people, that guidelines is a little different from the other one. So it's a pleasure to thank you all, seeing Ingrid and his team with us, and the beloved teachers with Atikul Haq and all of my other fellow colleagues, Minhaj Bhai and others, missing Minhaj Bhai in the department, and wishing his good health to be very soon to be in the department. And all your participation is really enlightened to us. Thanks Raj TV and the sponsors to helping to organize such a excellent program. Thank you very much.
Thank you, sir. A lot of issues were solved. Thank you, sir. Now, may I request Professor Minhaj Rahim Chaudhuri, General Secretary of Bangladesh Rheumatology Society, to some comments and raising the for solving the raising issues. Professor Minhaj.
Thank you, Honorable Chairperson, and other panelists, and as well as all our viewers. So it's a pleasure that we have organized this important webinar on spondyloarthritis. And first of all, I must thank two speakers. They brilliantly presented their talk. I am confident that all of we were able to enrich our knowledge. We are grateful to Professor Ingrid Moller of Spain. She is a great friend of ours. In spite of our very busy schedule, she has joined with us. Professor Raushan already said that an important issue we are noticing here in Bangladesh. I do agree with her. In fact, the prevalence of spondyloarthritis is increasing. And if we look back in our, we had one study in 2001, and the PI was Professor Syed Atikul Haq, and I was a teammate. And at that time, we observed our prevalence of ankylosing spondylitis. At that time, we used to we were able to diagnose ankylosing spondylitis, not spondyloarthritis. So it was 0.15 to 0.3%. And now another study here in Bangladesh, it was conducted, and the PI was Dr. Jahid Al-Qadir, and they found the prevalence of spondyloarthritis is 1.2%. So it's rising. And we and our patients are lucky that we have lots of options to treat now. And in future, if we can use all these small molecules, which are cheaper in our country, and that will be a great advantages. In addition, also, Dr. Masood already told that there are several targets, future targets, and that includes IRAP1, MMP3, TAP, LMP2, STAT3, ubiquitin, ROR gamma, proteoglycan, etc., lots of molecules, is really involved in the development of the spondyloarthritis. And in future, definitely, this will be also arrested, and the treatment will be very much easier and comfortable for our patients. And another issue has been raised here, that is the chronic low back pain, inflammatory back pain, and also the age. Definitely, we find some patients, even in our elderly patients, we find, and eventually we diagnose that the patient is having spondyloarthritis. But I would like to request you, in an elderly group, always we should try to exclude first malignancy and tuberculosis. And then we can exclude these two things especially, and there are some others too. Then we can proceed with spondyloarthritis, because these two other could be, so the diagnosis could be life-saving. And there are some other issues. I have seen one interesting questions. There were several criteria in the past, AMOR, ESSG, and then why the ASAS came. So the answer is like the previous two had some limitations, especially they did not address, the axial and peripheral, and they also did not include MRI. So these were the limitations, and even the ASAS has got some limitations. So this is important, and then I thank the audiences, and their participation has made this program successful. We are grateful to our media partner, Raj TV. Special thanks to Dr. Basu and his team, and also our scientific partner, Delta Pharmaceuticals Limited. There's some people, they worked relentlessly to make this program a success. And so with these few words, I am concluding my talk. Thank you, everybody.
Thank you, sir. And now, may I request the chairperson of this session, Professor Syed Atikul Haq, for his valuable comment on spondyloarthritis and also solving the raising issues. And after his speech, he will conclude the session. Thank you, sir.
Okay, thank you very much, Ahmed. And I thank Bangladesh Rheumatology Society for, I would say, selecting me as the chairperson of this very important session. So I, firstly, I would thank, Delta Pharmaceuticals for kindly sponsoring the events, and also Raj TV to be our, I should say, some sort of co-host or allowing us to use their platform. And I would say, actually, Shoaib has raised a very valid question, and the question has been greatly answered by Professor Nazrul Islam and also Professor Minhaj Rahim Chaudhary. But I shall simply remind that, our Dr. Alamgir Mushtaq Ahmed was quite clever. He mentioned in his speech that, ESR, CRP, or these APRs, acute phase reactants, may be quite normal in spondyloarthritis in some patients. And he has repeatedly emphasized the need for collecting multiple types of information from multiple sources, including history, a very meticulously taken history, then examination, meticulous examination, and also laboratory information, repeatedly reiterating that, this imaging sacroiliitis or HLA-B27 or sometimes even inflammatory back pain, these things may be absent. And despite the absence of these things, if we cleverly synthesize the available information, if we cleverly collect is also important, collection of information is also important. And if we cleverly synthesize them, they would help us greatly. For example, sometimes when I ask the patient, do you have, when your pain is maximum, is it in early morning upon waking up? What happens to the pain with activities? The patients often cannot answer properly. But if we ask, do you get awakened by back pain in the midnight or late night? They say yes. Or sometimes we ask, suppose you get up at late night for micturition purpose, do you find it impossible or very difficult for you to move because of the back pain? At that time, patient responds yes. So, we have to be clever in eliciting the appropriate or correct response from the patient. And this is particularly more true in our country, where the patients are often less literate, less educated, and less communicative also. So we have to put the answer in various form to the same patient. We have to ask the question in 3 or 4 different, thematic, I would say, expressions. That is one side, and more or less, I would say that, Shoaib, I fully agree that we face such dilemma more often, and we have to remember that the criteria are for inclusion, for maintaining homogeneity of patients enrolled in a research. Criteria are not designed for making diagnosis that we have to remember always. But in that case, when a patient doesn't fit into a diagnostic criteria set, we have to remember that we have to be very judicious in applying our clinical, acumen. That is very important. We often quite sensibly, we don't feel confident in our clinical acumen, and that is not an offense. That is quite good to be less confident. So, in that case, there is also ESSG criteria, and ESSG criteria is quite liberal. If a patient has got inflammatory spinal pain or asymmetric lower limb predominant oligosynovitis, then only 1 point will lead to meeting the criteria for spondyloarthritis. And that point may be simply family history, positive family history, that may be enough. So if we have excluded other differential diagnoses quite confidently and a patient fulfills the ESSG criteria, we can say, yes, this patient belongs to, this spondyloarthritis. Moreover, Professor Ingrid Moller has suggested that we can do, ultrasonography for identifying enthesitis. And there are many articles on asymptomatic enthesitis in psoriatic arthritis patient. And also, there was one research article that was basically published in the year 2006, that was quite early, by Augustino. He has shown that many patients with even spondyloarthritis, not only psoriatic, has got this asymptomatic enthesitis. And there are some recent reports of identification of asymptomatic enthesitis with the help of PET-CT. But in our country, we can do this with ultrasonography also. But in that case, we have to be cautious that, we have to charge the patient the same amount for entire enthesitis survey. For enthesitis survey, if we focus only on to the lower limb, that is enough. Because most of the enthesitis occur in the lower limbs, we don't have to spend time for detecting in clinical practice for detecting enthesitis in the spine or in the upper limbs. Lower limb is enough. But you should not be charged excessively for each individual area individually. If the fee is collective, the same, you keep 2,000 and you do enthesitis survey with ultrasonography machine, you may get asymptomatic enthesitis, and that will also add to the weight of evidences in favor of the diagnosis of spondyloarthritis. So these are all things. And actually, I have said many things in connection with Alamgir Mostak's lecture. Now let me switch to Masood. I would thank Masood profusely for highlighting very important issues in the management, like patient education and shared decision making, that is often ignored in our practice. And also attention to the financial resources of the patient, that is also very important. Stopping smoking, regular exercise, vaccination, and also exclusion of active tuberculosis in patients with, in patients in whom TST or IGRA has become positive. Active tuberculosis must be excluded. That is very important, and that is sometimes missed. And regarding Shoaib's second question about the use of small molecules in spondyloarthritis, Nuzrul has mentioned about the Epler recommendation. And I would remind Shoaib that, of course, I know Shoaib, that was an article was published in October 2020 on the role of small molecules, the prospect of small molecules in the treatment of, spondyloarthritis. And there, these three molecules turned out to be effective. This, tofacitinib. There are research evidences, tofacitinib, upadacitinib, and also filgotinib. And also there has been a recent article on the efficacy of baricitinib in spondyloarthritis. So small molecules are working, and they are being recruited in the recommended armamentarium. And I think if we recall the 2019 ACR SSA SRTN recommendation that was presented in our journal club, as I remember. I don't remember who presented that, but he or she presented very nicely. that ACR recommendation 2019 for ankylosing spondylitis has put tofacitinib in phase 3 in patients in whom TNFIs have been inadequately effective. So inadequate response to TNFI that has been recommended in 2019. So recommendations are there. You can use as per recommendation. And also we can go, as Nazrul has said, considering financial constraints of our patients, sometimes using our judiciousness and our conscience, we may go beyond the recommendation also. So, okay, with these words, I conclude my concluding talk, and at the same time, with thanks to you all, particularly thanks to Abu Shaheen and Minhaj for working very hard for organizing this webinar. I conclude this webinar. Thank you all, and goodbye.
Sir.
তাহলে এখন তো অফলাইন হয়ে যেতে ওকে
আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম। মাসুদ, থ্যাংক ইউ, তুমি অনেক সুন্দর সুন্দর।
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.